This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, let me take you through a case of an intraoperative surprise. It was least expected and I had to deal with it. Now, this is an 65-year-old gentleman who has had a mature cataract. Nothing significant, seems to be a very perfectly routine case. The phaco is done, the cortex is aspirated out, the IOL is implanted. I'm trying to remove the OVD, and as I'm doing that, I feel that there is some amount of cortical fiber here. I'm just trying to aspirate it, and then I realize something is abnormal. These fibers are not coming from within the bag, but they're coming from around the bag. Well, this was a surprise. Well, this was nothing but vitreous which is prolapsing from the zonules. Well, why not from the equatorial PC? Well, I can see the pupil is very well dilated, the lens is well centered, I am unable to see any defect in the posterior capsule as of now. So, although the differential diagnosis of considering equatorial PC tear is wise and should always be looked for, but in this case, because of the absence of any visible tear in the equatorial region of the posterior capsule and the lens being very well centered, which wouldn't have been the case if the PC tear was in the same region as the haptic is. So this would suggest that we are dealing with an transzonular prolapse of the vitreous. So how do we deal with it? Let me take you through a step-by-step approach. Now, the first question, would you want to try the pass-pan approach or the limbal approach itself? Now, my first preference always is going to be a limbal approach because it would prevent me from making another port. And in the worst case scenario, if I'm not able to deal with it, then maybe I'll consider it later. So as of now, a limbal route is my approach. So the first I do is to inject a diluted triamcinolone acetate. So the dilution is created by taking about say 0.2 ml of triamcinolone acetate in a 1 ml syringe and adding BSS to make it 1 ml. So it would give a concentration of 1:5. And the moment triamcinolone acetate is injected, we can see the vitreous which is prolapsed out through the wound very clearly visible. So how do we deal with it? The first thing to do is cut the vitreous at the wound itself before introducing the cutter into the eye. The moment we cut the vitreous at the wound, the part of the vitreous which is prolapsing from the zonules and prolapsing into the incision falls back a little bit. Then we can introduce the cutter inside and then the vitrectomy is continued. But one needs to be very mindful at this stage that we don't want to damage the iris as well as the rhexis margin, which are at close vicinity. So it's important to be mindful of this fact. Now, once I'm certain that the vitrectomy is done and it's adequate, I go in and dial the lens so the haptics are away from this area. I'm just still continuing to do a little bit of a vitrectomy at the wound just to confirm that there is no vitreous left at the wound. Now, pupil is quite regular in that area. There's no peaking, which suggests that there is possibly no vitreous strand coming across. But always it's better to confirm it once again either by using triamcinolone acetate or pilocarpine. I'm going to hydrate the incision first, and I'm just going to place in 0.1 ml of pilocarpine. The chamber is being constantly irrigated with my left hand, and in a few seconds the pupil comes down, and I'm just searching for any evidence of pupil peaking which could hint that there could be a vitreous fibers which is still coming around. I find none, and that should be confirmatory that we don't have any vitreous prolapse. So whenever we have a transzonular vitreous prolapse, I think always better to try with the limbal route itself. Most often than not, we'll be successful in dealing with that. And I begin by first clearing the vitreous at the wound. This will push back some of the vitreous fibers. Then we enter through the same port and deal with that prolapsed vitreous. In some situations, we may have to switch hands and maybe use the other port, which was not a necessity in this case. Before closing, I'd just like to reconfirm the absence of vitreous by injecting a little amount of triamcinolone acetate once again, and there is none. Time to close. With the left hand still irrigating, I'm just going to hydrate the side port incisions. The irrigation comes out, the other ports are hydrated, and that's it, the case is done. So this is a short video about how to do vitrectomy when we have a transzonular vitreous prolapse? Well, the bigger question, why did it prolapse? Well, I don't have any answer for it. We asked the patient for any history of injury in the past. It wasn't there. So we do have to live out with some surprises which remain unexplained. So that was it. Thank you for watching and hope you found this helpful.